In case you missed the last news release from the Centers for Disease Control, they announced about a week ago that the life expectancy in the United States declined in 2017. You're done. While I thought I made that clear, I guess I didn't. I'm sorry. The life expectancy in the United States declined in 2017, while deaths from drug overdose increased over 9.5%. Robert Redfield, the director of the CDC, said, and I quote, "Life expectancy gives us a snapshot of the nation's overall health, and these sobering statistics are a wake-up call that we are losing too many Americans too early and too often to conditions that are preventable." To close out today's conference, I would like to introduce you to Dr. Karen Smith, who will provide the keynote address and will discuss the opioid epidemic, which I don't need to tell you is challenging our entire country. Dr. Smith has served as the director of the California Department of Public Health and state public health officer since 2015. She's a physician specializing in infectious disease and public health. Prior to her appointment, she served as the public health officer and deputy director for the Napa County Health and Human Services Agency back since 2004. Dr. Smith, we await your address.
It's always fun to start a talk with "we're all going to die." It happens to be true. In case you thought it wasn't, we are all going to die, but not right now. So I am actually a little bit of, not quite as much as the food scientist, so thank you very much for bringing the food panel, because I was feeling a little bit not fitting in with all the healthcare mantra of today. But I have to say, I was speaking to somebody at the break, this is the first time I have ever been to a healthcare conference, and I've been to many, where the focus was social determinants of health. And that's incredibly encouraging to those of us for whom that is our world, working in the social determinants of health. So I have roughly 20 to 25 minutes to talk a little bit about what really determines health. I'm just going to try to give you a little bit of a framework to think as we move forward. What is public health and how it differs a little bit from the healthcare system, the shape of the opioid crisis, and to try to put it in a little bit of context of the things that we've been talking about here today. And I'm going to talk a little bit about California's approach to the opioid crisis, because I think it really does epitomize a public health approach to a problem that is both a healthcare but also a societal issue. So let's start with sort of an academic look at what really predicts health. So if we start at the top there, I think I have a, these are the health outcomes. This is what y'all are measuring, those of you who are talking about data in healthcare, whether it's disease rates or mortality rates. It's mortality rates that are currently going up. And we know for a fact, in fact, most of us study and work on what are the health factors, what are the things that affect morbidity and mortality. After all, we can't directly affect it, so we're trying to figure out what is it that whatever is it that creates health, essentially, and or challenges health. And so most of the conversation in the United States over the last 150 years has been about the health care system, and that has predominantly referred to the medical care system. But if you look at the data, and there's a lot of data out there, what we find is that access to, even if you guarantee access to high quality, affordable health care, at most, you can account for approximately 10 to 20% of the positive health outcomes over the course of a lifetime. Especially when you look at a population level, which is, I look at population levels, but the whole population as opposed to, say, patient population, but this holds true for most populations. So clearly there's something else. Now, the world of public health has historically, as distinct from healthcare, we've dealt with this other issue, which was the rest of the conversation until very recently in health and public health, and that was basically health behaviors, or as most of us thought about it, things that, quite frankly, you should be able to control yourself. So, and public health, this was our world. We could frankly go back to up to the moon and back several times if we just stacked all the brochures that we've put out about health behaviors over the last 50 to 100 years. Literally, don't smoke, don't eat red meat, don't be sedentary. We were the people of no, and don't do anything that's fun or tastes good. Because we really, and honestly, don't have unprotected sex, because that's the most fun and the least healthy. So, you know, this was our world. It's not a particularly encouraging world to work in. People don't love you for it. But between these two things, we thought, well, okay, if we can get a handle, if we can change people's behavior. How many times have you heard that comment today? If we can change people's behavior. And I've heard several speakers talk about what we know doesn't work to change people's behaviors. The only people who know how to change people's behavior, I think, are marketers and Amazon. The rest of us are still trying to figure it out. But even if we look at health behaviors and take that into account, it really only accounts for, at most, and this is being generous, 40% of overall health outcomes. So something's missing. This isn't everything. Even I don't do math terribly well, but I know that doesn't add up. Even if I give you 20 plus 40, that is not 100%. And we'll throw in 10% for genetics. That's probably an overestimate, but we'll give it some points. We're still nowhere near 100%. And it's only in the last 15 years or so, and particularly in public health, and now, as of today, officially, in the healthcare system conversation, we figured out where the rest of the equation is, which is essentially in the way that people live, and the way, where you're born, the opportunities that you had, the physical environment in which you grew up in, the social and economic opportunities to be healthy that you had growing up and as an adult. This is the rest of the equation. And overall, this is by far the most powerful part of the equation. Public health focuses largely on prevention. Now, the healthcare system does as well, although it tends to be personal prevention or individual disease prevention activities. Our job in public health is to take steps further and further back toward root causes, because we have much less money. Just to give you an idea, my sister department, the Department of Healthcare Services in California, has a budget of around $100 billion. I have a budget of $3 billion. So that, I think, in a nutshell, basically shows you what we value and how much we invest in the different aspects of what's basically a family relationship between healthcare and public health. So for us to be effective, we have to get as far back to root causes as we can and try to find those levers that are going to make the biggest difference downstream from where we are. And so in order to do that, we use this work, this data about what works and what levers we can pull to create policies and programs that hopefully then will impact the health factors and have a long-term impact on health outcomes. This is a graph from my colleagues at the Bay Area Health Inequities Initiative that kind of demonstrates some of this. If you look down here at the your right-hand part of the screen, this is where most of the conversation around health has been in the United States. We measure disease and injury, we measure mortality. We've had a lot of time trying to figure out risk behaviors and how to make people healthy by changing their behavior. We're starting to really take on, and that includes the healthcare system, these living conditions and social factors that drive the opportunities that you have to be healthy. But really, if you want to work upstream where the biggest causality, the root causes are, they're not here. They're actually in inequities that are embedded in our society. So down here we talk about disparities, and I want to be really clear on the language because not everybody gets it. Disparities are differences in numbers. There are disparities between health outcomes in African Americans and whites for basically every disease process. That's a disparity. Those disparities arise from the inequities in the way those two populations live and the opportunities that they have and the risks to their health. So what we're focusing on nowadays in public health really are the inequities in the system, that from institutional inequities to, quite frankly, societal inequities, including things like discrimination and racism, et cetera. But most of these, I want to be clear, most of these are not intentional. They've been built into the system over many, many years. But until we recognize them and call them out and explicitly address them, we can't fix them. So health equity is what we're trying to achieve in public health. And what that means basically is that every single person in a community has an equal and just opportunity to be healthier. And to do that, we really do have to address the obstacles to that. And those obstacles include things like poverty and homelessness and discrimination and the consequences of those. And the most powerful indicators or causes for long-term health outcomes actually have to do with things like feelings of powerlessness, lack of access to jobs and the social capital that you get from being employed and having fair pay, quality education, housing, stable housing, and safe environments to live in. It's not an accident that communities next to large Superfund sites and dumps are almost inevitably communities of color. These are the kinds of built-in discrimination and discriminatory practices that I'm talking about. So this is the mission of public health ultimately, is to try to create that equity in opportunities to be healthy across our countries. But public health, basically what we're trying to do is create healthy people in healthy and resilient communities. And that term resilience has come to be incredibly important. And I'm not talking just about resilience to natural disasters. Goodness knows we've had plenty of those in California and elsewhere in the country, but also resilience to economic downturns and other kinds of impacts to communities that occur. We can't stop those things from happening. We can prepare as much as we can, but what we really need to figure out, and public health focuses on community rather than individual. We do provide services to individuals, but overall, our goal is trying to create healthy people in healthy environments that are resilient to the slings and arrows that are so famous. The tools that we use are assessment. We do systematic collecting and analyzing data and turning that data into information that we can feed both to our partners in healthcare, to the policymakers, but also back to communities. Ultimately, communities are the most powerful agents for change within their own environment, if you give them the tools. We use that knowledge to promote policies that then, being based in hard science, hopefully will be more effective. We still have an assurance function. Historically, public health was the safety net provider of last resort, providing primary care clinics. As we expanded in the United States, the access to quality healthcare through the healthcare system, we've had less and less need to do that. And it's a good thing because, quite frankly, the healthcare system's way better at it than we are. Public health is fundamentally a government function, and we just don't do that very well. The healthcare system is much better. We still work to ensure that we understand the provision of services and that those people who are at highest risk and most vulnerable actually have access to the services that they need, not just healthcare services, but also social supports. That's a big part of the work that we do as well. At heart, public health really is a science. We are a data and information-driven field. These are the core sciences for public health. Most of you are familiar with the concept of surveillance, monitoring over time. Epidemiology is basically taking all that data and putting it in a context. We study how diseases and conditions originate, how they move through populations, and what are the risks and protective factors, both for populations and individuals with respect to given health conditions. The laboratories not only do testing, but we also do a lot of research. Our laboratory in California actually first elucidated what the particulate matter was in air pollution that has negative human health effects. So we have a large role to play in research and development in public health labs. Public health informatics, we're not in our infancy, but we're definitely still in childhood. We have access to masses of data. I have 23 different disease registries with over almost 50 million people's information in them. They don't talk to each other, and they're in different forms, and they have different bits of data in them. And so learning to leverage the data that we do have in a way that turns it into information that's actionable is a huge challenge for us, and it's a massive interoperability challenge that we're learning from our colleagues, frankly, in healthcare on how to proceed with that. And then really important is prevention effectiveness. So we're all about prevention, but we need to understand what actually works and why it works and in what populations, because as has been said here several times today, health is local, and that's true for communities too. While there are certain general things that we know are true to encourage, to maintain health, they're different in each community because each community is different. And so we are fundamentally a community localized entity. Just a word about when most people think of public health, and I mentioned a government function, governments were developed originally, if you go all the way back, to assure public safety and health. Those were the core functions, and right after that came trade, right? The military followed soon, but that's another topic. The provision of public health services was a foundational thing. Really, basically, you don't want your water and your sewer running right next to each other, even though the human body is kind of sort of designed that way. Who knows why? But if you're living in a big city, you need to ensure those kind of basic services, and that's where governmental public health grew up from. Our basic foundational services remain the same: communicable disease control, chronic disease and injury prevention work, environmental public health, which is, in addition to things like restaurant safety, we regulate a lot of the radioactivity that's in use in communities and things like that. Maternal, child, and family health is a huge part of what we do as well as that assurance function with respect not just to clinical care, but the provision of human services. And then vital records, all your births and death certificates, your marriage certificates, et cetera, which provide the foundation for a lot of what we do, particularly mortality data. But public health has always existed in a system. The work that we do is done in collaboration with other entities. Historically, it's been other organizational entities, whether it's the faith community, law enforcement, other government entities, tribes, et cetera. We still work in this community. We work by bringing together cross-sectoral groups to work on issues and talking about how we can align our activities. We're very good at convening. We bring people together because we don't have any money, we can happily, and we don't need the power, we happily bring people together and try to get them to coordinate. And it's something that we've been doing for 150 years or so. But what's changed is our recognition increasingly that we really need to bring the community itself into the conversation. Because ultimately, if you can engage communities and activate them around the issues that are impacting their health, then you have a prayer of sustaining those improvements. It's only when people are willing to go up in front of their electeds and demand what they feel they need in order to be healthy that the rest of us are going to be successful in providing those services to them. So a lot of our work nowadays is around what we call place-based health initiatives. And these are within a community, and community can be defined everything from a state, though not one as big as California, from a region, a county, to a neighborhood. But bringing together all the different sectors that have a role in that community, understanding what the people who live and work there believe are their major issues, and then working with them to provide them the information that they need to understand what can help them achieve their outcome. Whether that's violence or whether it's diabetes, the process is the same. The key is respecting that the community really does know what they need to be healthy, and then working with them to achieve that. Not every community is in the same state of readiness, so it takes a whole lot of patience. And many communities have an absolute distrust of institutions and government in particular. And you have to come with humility and a true, genuine respect for their agenda over your agenda. But when you do, it can be incredibly powerful. So let me move on to the opioid epidemic. I think everybody around here is probably aware that we have a challenge with opioids. Anybody not heard about that? Okay, good. Here's what you may not know. This isn't a new problem. Here we are, about to be in 2019, and there have really been 3 waves to this epidemic, or this crisis, as some people call it, in the United States. In 1990s was when we first started to see an increase in the prescribing of opioids. And you've, I'm sure, all read about the evil pharmaceutical industry and how they were leading poor, misguided physicians into treating their patients with too many opioids. And you know, there's villains and there are good guys and there are bad guys. The bottom line is prescribing increased dramatically. This is on a background, however, that we don't talk about very much, which is many years, in fact, decades, of waves of addiction. So alcohol addiction, by the way, is still the most prevalent drug of abuse in this country, hugely expensive to our society and largely ignored because it's socially acceptable. That's always been here. It's here at an increasing rate. We have more people with severe problems with alcoholism, costing the system a great deal of money and causing early mortality. We also have had heroin for a very long time. Heroin's been around since the 1950s, and its use peaked then later in the 1960s as well. And then there was methamphetamine, and there was MDMA. And we still have methamphetamine, by the way. More people are addicted to methamphetamine or are having severe outcomes than have overdoses from opioids. This is an issue now because the healthcare institution really accelerated, healthcare sector accelerated this with unsafe prescribing, not entirely, certainly not intentionally, but it is a distinctly different piece of this. The prescription drug piece of this epidemic is unusual and has created much of the more recent, from 2010, for example, or I'm sorry, in the late 90s, this is when this really started to take off, as you can see. And then in around 2010, we started seeing increases in heroin again. And then the most concerning thing is starting in 2013 is this, you will never see a peak like this outside of what we call a point source outbreak of some incredibly contagious disease. Those are fentanyl overdoses and deaths, which is an incredibly dangerous new and terrifying problem that we're having across the country. So I'm going to talk a little bit about California because it's the system I know most, and I think it exemplifies what the epidemic looks like, but also how we've been approaching it. So in California, we look good. If you look at our overall rates, our rates are lower than most of the rest of the country. But if you look a little bit closer, you will see that we have parts of California, these are our counties, that have opioid overdose and death rates that are as high as anywhere else in the country. And those are largely very rural, impoverished counties, just as they are elsewhere. We have, because we're almost 49 million people, the sheer magnitude of the issue is huge, even though the rates are overall less. We have over 2,000 deaths a year associated with opioids, over 8,000 hospital and emergency department admissions every year, and over 24 million prescriptions written every year for opioids. In some of those counties, there are 5 prescriptions per resident every year being issued. So we do still have a problem. And this burden, this pattern has been consistent throughout the opioid epidemic. So what do you do? I Googled the other day how to address the opioid crisis, just for fun. And it's remarkably consistent. Mandate prescriber education, implement prescribing guidelines, integrate prescription drug monitoring into clinical settings, improve data collection and sharing, treat overdose deaths, Narcan, naloxone, to treat overdoses to prevent deaths, and then increase the availability of medically assisted treatment. Nothing surprising there, right? It's great. And it works up to a point. We have done all of those things in California. And since 2012, we have seen an overall decrease in our opioid death rate. And we have seen fewer prescriptions being written, and we have seen fewer milliequivalents per prescription per resident being written. All good, but our rate of heroin-associated overdose deaths is increasing, and the rate of fentanyl-associated deaths has increased almost 200% year over year. So it's not enough. When you read about addressing the opioid epidemic, the piece of it that they're talking about is the healthcare associated piece, the prescription drug piece. But this epidemic morphs as you implement interventions. And this is not something new. We've seen this ever since the county in Illinois that had such a dramatic outbreak of HIV as the first indication that they actually had an opioid problem. As you decrease access to prescription drugs, you divert people into the illicit drug realm, which is a much, much harder problem to solve. So the opioid crisis, from our perspective, is actually a classic public health problem. For one thing, it is preventable. It is absolute. There's nothing absolute about this epidemic, but it does require that you have a multi-sector and multi-front approach on the problem. You cannot do one thing. You cannot just look at prescription-associated deaths and overdoses. Oh dear, I'm going to have to hurry here. Data and surveillance are key, and I'm going to talk a little bit more about this because I think it's so incredibly important, and it's something that many of you are working on indirectly, even though you're not necessarily applying it to this specific problem. And the only way we're going to be able to address this is through policy and systems change, ultimately. So in California, we have a multi-sector working group that includes, at this point, over 22 agencies, both at the local, state, and state level in every sector, and also over 40 involved agencies in 5 task forces that are addressing a variety of issues. Essentially, what we've done, I'm going to go past this, is to create a suite of mutually reinforcing activities that span everything from policy change, data acquisition and analysis, education both of providers but also of communities to try to reduce stigma and get an understanding of the issue and activate them around this issue within their own communities. All of these things, increasingly, as we find new things that are working, are both being implemented and being evaluated at the same time. Each community looks a little bit different. We have 17 regional opioid coalitions all working on this problem, trying to get the best mix of interventions and systems changes for their communities. And when I say multi-sector, I'm talking the healthcare sector is at the table, law enforcement is at the table, government is at the table, nonprofits, and community members themselves, people who have been directly impacted by the opioid epidemic. And it's making a difference. I want to just spend a couple of minutes on surveillance because this is a fascinating issue. Surveillance for opioids, you all, many of you in the audience, how many of you work on interoperability data in some way or shape or form? Quite a few of you. So you know, and you from Staten Island, I want to learn from you, are doing an amazing job of pulling data down from a variety of sectors. To really understand what's going on in the opioid epidemic, you need to, I'm going to skip through this, to say that what we really need is not just data from the healthcare system. So we know where the overdoses are occurring. We know who's, a bit about the people who are getting it. We know the tip of the iceberg. What we need is data that tells us who's going to have an overdose, which community is going to have an outbreak. And that requires a huge number of different data sources. For example, we have not yet linked all that. Remember, California is really big. I think we have something like on the order of 17 health information exchanges, and I don't know how many electronic medical records. So we need to integrate with those. We need coroner and medical examiner data. It's a very different kind of data. It gives you context about the person who died or overdosed. The laboratory data, is there fentanyl involved? Is there carfentanil involved? Is there multi-drugs? Law enforcement data provides us a lot more information about the person and the context of that person's environment when the overdose occurred. Correctional data, there's a huge intersection between opioids in the community and opioids in persons who've been involved in the correctional industry. But ultimately, the opioid crisis is a another disease of despair, the sort of diseases that we're seeing increasingly in the United States as more and more people are falling off the edge, are being left behind, who simply do not see a way forward to a prosperous future for them and their families. Whether that's because they had a healthcare crisis and they lost their job and now they're marginally housed or living homeless, whether it's because they became addicted to opioids when they had an industrial injury, couldn't get off it, the hopelessness and the helplessness that people feel, the anxiety and the depression, don't just lead one to opioid use disorder, but to all the other chronic diseases. We know that anxiety is one of the most powerful drivers of chronic pain, which then, of course, leads people to approach the healthcare system with pain, which leads us to try to figure out how to deal with their pain. And as long as we remain hyper-medicalized and want to use pills and medicine for everything, we're going to continue to run into this kind of a challenge. So it isn't just about the healthcare industry expanding its approaches to pain and adding alternative therapies that we know actually work better than opioids. It's also about us building communities that are resilient enough and have the safety nets to catch people who have mental health disorders, who have had challenges, who have a history of violence in their family, who leave home because they've been sexually abused. There are a lot of people that we're leaving behind. And this epidemic and its associated epidemic of suicide and sexually transmitted diseases are all fundamentally social problems. This one just happens to have a huge healthcare component. And that component we know how to fix. You can find it on Google. If you do all those things, it really works. The problem is the rest of this. So I leave you with that challenge. When you've finished fixing the healthcare system, come work with us. We'd really love your help because this is hard stuff. And thank you very much.